My name's PaigeTucker. I currently work at St John of God Hospital in Subiaco in Western Australia, which is a Catholic private institution, but very supportive of research, and they're very supportive of me. And I'm doing my PhD at the University of Notre Dame, and which is also a Catholic institution, so I'm kind of bucking the trend in researching sexuality into Catholic institutions. First of all, I'd just like to say a big thank you for having me. Thank you to Helen and to Selva for having me. I met them in Penang and they said, hey, how about coming over in November? And they've provided the funds for me to come here and talk to you today. And thanks to the Flinders Cancer Centre for also having this amazing workshop, which I'm amazed about, and we're hoping to do the same thing in WA, hopefully next year. So one of my supervisors actually told me you should tell people what you're going to tell them, and then tell them what you've told them. So today I'm hoping to cover the biopsychosocial model of sexuality, just to give you kind of a basis to think about sexuality within humans, but more specifically within women. We're going to look specifically at the effects that cancer can have on sexuality in women, the rates of sexual dysfunction with cancer, common sexual side effects that these women experience, the treatment options, and then if I have time, I'll talk about my research, which is sexuality in risk-reducing salpingoophorectomy. Okay, so I think any of you that went to a university would have been introduced to the biopsychosocial model. We certainly had it shoved down our throats during public health, and it basically involves that most diseases and illnesses are based on this triangle of the biological, the psychosocial, the psychological, and the social. And so I'd like to think of sexuality in that way. But instead of saying biological, we actually think of sexual capacity. So that is the actual physical capacity for that woman to engage in sexual activity. Then we look at sexual attitude, and that's her thoughts and her feelings about sexuality. That's her desire to have sexual activity. That's the way she thinks of herself as a sexual being, but also the way she views her partner or potential partners in a sexual manner. And then sexual opportunity is literally the opportunity she has to engage in sexual activity with another human being. So when we think of cancer and its ability to affect sexual capacity, particularly within gynecological cancers, we can see that there's actually a direct correlation between a woman's sexual organs and the cancer. And women, unfortunately, their cancers affect a lot of their sexual organs. So I'm not just talking gynecological cancers, ovarian, uterine, cervical, vaginal, vulval. We've got breast cancer as well, we've got rectal cancer, we've got mouth cancer, we've got head and neck cancer, we've got all of these things that are actually involving our sexual organs, and they can directly affect our capacity to have sexual relations. So when we think of gynae cancers, if we look at vulval cancers, for example, and the pain associated with a vulval cancer before it's treated, that's going to impede on that woman's capacity to engage in sexual intercourse. And dyspareunia, if you've got a large ovarian mass, so dyspareunia is pain and intercourse. If you've got a large mass sitting there, it's really uncomfortable to have penetrative sex. So that's going to affect her ability to have that. So cancer itself can directly, in its just presence, can affect that woman's sexuality. But more commonly, we see that cancer treatment is the one that affects sexuality. So I already talked about surgery and all the amazing surgeries that the gynae-oncologists do to prolong life and to give women the best hope of surviving this. But it's these very treatments that then go on to cause lots of the sexual problems. So most commonly, there's a hysterectomy. So you've got uterine cancer or ovarian cancer or cervical cancer, and the recommendation to prolong life is removal of your uterus, which is really fine if you're like most women in the world and you have clitoral or vaginal orgasms. But if you're one of those lucky few women that orgasm through their uterus and you're having your uterus removed, that surgery is essentially removing your ability to orgasm satisfactorily. So that's having a direct effect on the experience of sex, as well as your desire to then undertake sex that is unsatisfactory. We look at vulval cancers. You have a vulvectomy. Sometimes those vulvectomies involve the removal of the clitoris. They can change the sensation in the vulva. They all have direct effects on the capacity of that woman to engage in sexual activity. And when we look at the other kind of cancers, breast cancers, mastectomy, changes in sensation. If you're a woman that really likes to have your breasts involved in your sexual foreplay, the removal of those breasts is actually going to significantly affect your sexual capacity. And then we go on to chemotherapy. So you've had your surgery in most cases, and they go on to have their chemotherapy. And I don't know about you, but I can't imagine anything less sexy than constantly feeling nauseated. Feeling nauseous, getting neuralgia or change in sensation with chemotherapy, feeling lethargic. But on top of that, we also have the fear that women have when they have chemotherapy, that their chemotherapy agent is going to affect their partner. So they're often afraid to engage in sexual activity with their partner because they then feel that they're somehow going to have a toxic effect on their partner. And the chemotherapy itself, the complete, the experience of chemotherapy, the survivorship, and looking at going through all these routines often means that those women go through several months of treatment, and during that time they're feeling horrible, they're not interested in engaging in sexual activity, and it can have a massive effect on their sexual capacity. And we heard from Linda about radiotherapy, and we know that radiotherapy significantly affects a woman's sexual organs, vaginal stenosis being the primary one. So vaginal stenosis is the thickening and often shortening of the vagina, which can cause significant problems for women for penetrative sex. And there's obviously the options of dilators, which we'll go through later, but it can completely change the way that a woman is able to function sexually, as well as how she wants to function. In the short term, we've got proctitis, which is inflammation of, the rectum, or cystitis, inflammation of the bladder, and all of these can cause, diarrhea, but also pain and problems with sex, and that's the short term. And then you've got the long-term stenosis. So radiotherapy as a treatment directly affects the woman's ability and capacity to have sex. And then there's the effect of menopause as well. So in ovarian cancer and many cancers, the recommendation is also to remove the ovaries for optimal treatment. And in particularly young premenopausal women, this will put them into early menopause. And associated with early menopause, hot flushes, irritability, and none of those really put you in a particularly sexy mood. But it can also be associated with high rates of reduced libido and vaginal dryness. So all of these can affect the woman's desire to have sex, as well as her actual ability to engage in sexual relations comfortably. And the thing that I think is often also missed is the effect of follow-up on a woman's capacity to have sex. So for those of you that are gynaecologists or have had experience of cancer and have had to go in for a checkup to look for vaginal cancer, and your lovely gynaecologist will actually spray the inside of your vagina with iodine, which burns terribly. So that woman has got this horrible burning vagina when she leaves the practices, and she's not going to want to go home and engage in relations with her partner. She'll be feeling pain, she'll be washing out, and that was going to affect her capacity to have sex. And if for some reason there's something that's a little bit odd that needs a biopsy, so you've got the pain of the biopsy and the potential bleeding of the biopsy, and then they dab silver nitrate to stop that bleeding, and then that's going to affect anything that's put inside of her. So we recommend you don't have intercourse for a few days after this in order to not have that silver nitrate go to her partner. So in all of this follow-up, and if this is happening every 3 months, every 6 months, I mean, it doesn't seem that big a deal to us, and we think, oh, it's better that we know what's happening, whether it's a recurrence, but this is actually going to be upsetting their sexual routine and having an effect on that woman's sexual life. So as you can see, there's lots and lots that can go wrong with sexual capacity associated with cancer. But it can also affect, as the arrow showed, that they're all interrelated. So as a result of that sexual capacity and biological model, we get effects in the woman's sexual attitudes and how she feels. And I think the first thing that happens is survivorship. Women with cancer who get diagnosed with cancer, our normal responses is to think, we've just got to survive this. Just got to get through it, get to the next appointment, get to the next treatment. You know, your focus is on surviving this cancer. And nowhere in that survivor kind of mentality is there a thing where you say, oh, well, I've kind of let my sex life go a bit, I better focus on that for a bit. You don't. You can't. You focus on your survival, and the sexuality side is not seen as so important, which is normal, but it does affect the attitudes of importance of sex and relations. Psychological stress can have a huge impact on sexuality. Not only, psychological stress of the cancer, but the anxiety associated with every kind of follow-up, with every treatment. Feeling constantly anxious or scared is never going to put you in a particularly high sexy mood. Depression that comes. So not only does depression, we know, reduce your sex life and your sexual functioning, but the antidepressants that you're given to treat your depression will also affect your ability to orgasm and your libido. So the treatment as well as the actual disease can affect sexuality. Body image issues. So we've just removed a large portion of your vulva and your vulva doesn't look the same, and that's going to have some psychological ramifications when it comes to going to, having sex with your partner. Suddenly you're self-conscious about bits that you weren't really self-conscious about before. Breasts, so if you've got breast ovarian cancer syndrome and you have a mastectomy, that's a big thing for a woman to lose her breasts and to still feel sexy and still feel desirable. There's still that awareness during those relations that, maybe it doesn't feel the same, doesn't look the same. Is he or she turned on by my new body? Am I feeling good about my new body? So when you're constantly aware that you're not feeling or looking as good as you could, it's going to affect the satisfaction you get out of your sexual relations. As Arian Silver talked about, the femininity side of things. When you've removed all of your female bits, are you still a female? There's lots of studies that have shown women say, I feel like I'm going to become a man. What have I got left? So when you are feeling like you're not a woman, how are you then supposed to be a woman in your sexual relations? So that's, and particularly I think in cervical cancer as well. So we're often removing very young women's ability to be fertile, to be a woman, to be a mother, and the psychological things that are involved with that often impact on her sexuality as well. And coming to that, so sexual attitude is also linked to sexual opportunity. And sexual opportunity was the ability or opportunity for a woman to have sexual relations with someone else. And this is often affected by social interaction. So if we take that young woman, for example, we had a girl, 23, and she got cervical cancer, advanced cervical cancer, and we had to offer her the optimal treatment to save her life, which was to remove her uterus and her ovaries. And this is going to affect her social interactions, because she said to me, when do I broach this? I'm not in a relationship. When I meet a guy, when do I tell him that I'm on HRT and I have no ovaries and no uterus? Do I tell him when I first meet him? Do we go on a few dates and then I tell him? Do I tell him just before we have sex? Do I tell him after we've had sex and he's maybe wondering why I feel different? And for her, the stress of when to talk about it means that she's really scared about going out and meeting someone. So she's actually avoiding social interactions where she would potentially have a sexual partner because of the effect of this treatment. And so when we consider sexual opportunity, we need to actually look at it in a relationship kind of context. So no man's an island. And while we as women have our sexuality triad of biopsychosocial, so do men or women if you're in a lesbian relationship. So the sexual opportunity has to be taken into account with that other person's sexual opportunity as well. And their sexual opportunity is affected by their sexual capacity. So prostate, for example. So the number of women I've talked to, I've said, how's your sex life? And they say, oh, we haven't had it for a while. My husband had a prostatectomy 10 years ago. At which point I say, well, how's your sex for one? And they look shocked. But they link their sexuality so much with their husband's sexual opportunity. Her partner's sexual opportunity has been affected by his biological factors, and it's impacted on hers. When you think of also a partner's sexual attitude, we can put the woman's cancer into that as well. So lots of women say, I feel that my husband doesn't find me attractive anymore, or think that I don't look as good, and we reassure them, no, I'm sure it's fine. But men are people too, and they actually might not find their partner's new body attractive. They might be a boobs man and find her mastectomy not very attractive. He might look at her new vulva, her vulvectomy, and think, oh, that doesn't look right. And so men are human too, and they may have their sexual attitudes towards their partner affected by the very things that we're scared they're going to be affected by as well. They might be completely scared shitless that their partner's going to die. So they're going to deal with their own anxiety, their own psychological issues, their own depression in dealing with their partner's issues of cancer, and that's going to affect them, their sexual attitude. They might perhaps think that the woman's genitalia, because they've got a cancer in there, they see that sexual organ as diseased or ill. They see that any sexual function or sexual event with a diseased organ as repulsive or not in the best interest of the woman. So they might avoid wanting to have interactions with that woman out of kindness for her, while she's feeling, oh, he doesn't really think I'm very attractive. So there's all of those sexual attitudes that go into play to affect the sexual opportunity. And I think it's really important to remember that if there are problems in the sexual relationship or in the relationship beforehand, they don't magically go away when one of them is diagnosed with cancer. They intend to actually just get completely ignored. And then suddenly, where women are surviving longer, and these issues are still there, but then they don't want to be broached by the partner, and that affects their sexual opportunity. And there's nothing worse than when you've got a partner who's vomiting, who you are feeding, who you're perhaps toileting, who you are washing during her treatment, and then suddenly thinking, well, I think I want to go and have, sex with her tonight. That's not going to happen. So in many places, the carer role takes over and the sexual relationship actually gets completely lost in that. And it's a really difficult thing to do, to balance the carer role, the concern for your spouse or partner with a sexual life. It's a difficult thing. And that's one of the things that we need to consider when we're thinking about sexual opportunity for these people. Okay, so that was really emotionally exhausting for me. So I'm just going to take a little bit of a time out from that. And in my opinion, nothing kills human emotion more than a bit of statistics. So, let's take a bit of it. Who wants to put out there what they think the general population rate of sexual dysfunction is?
Is that 50% diagnosis of cancer?
This is in everyone, not in cancer. 50%?
I'd say 75.
75%? So this is general population. This is if we took a screen of everyone. 50, 75? It's actually 12. So this is... We're not going to read into that. So this is based on a study of 30,000 women in the US and came up with about 12% had some level of sexual dysfunction. Okay, now gynaecology. What do you think gynaecology patients, the rates?
50%.
50%, so you think everyone is the same? Yeah, 50%? Yeah. 75%? Yeah, so it's 60 to 85% depending on the cancer and the treatment. So it's, a huge proportion. More women have sexual dysfunction than don't when they've got gynecological cancer. And I think that's something that's really important, and we'll talk about it later in discussing cancer, is actually just saying that to women, that we know that you are more likely than not to have some sort of sexual dysfunction from this experience.
Where did you get that figure from?
That from numerous sources. Okay. Yeah, as I said, depends on.
Clinics.
All clinic will be about 12%.
Well, you'll see I could quote my study for you a bit later. Okay, so we'll just go through kind of some of the common sexual issues, and this is going to tie into my talk later and where we kind of work out ways in which we can discuss sexuality. So there are a whole range of issues that women experience. So dyspareunia is a very common one, so pain with intercourse. Vaginal dryness happens up to 90% of women, especially in menopause, and that can then also lead to dyspareunia. And I had a delightful couple I saw the other day, bantered amongst each other, had a great laugh, and when I asked them about sexual activity, and his response was her vagina has teeth. And it was obviously quite a bit of excuse the pun, a sore spot for them. And she's just got such severe vaginal dryness, it was affecting him, and we thankfully managed to work through it. But it's a major problem and can actually ruin lives. So vaginal stenosis from radiotherapy occurs in about 40% of the time. Low libido is extremely common. As we age, we get low libidos, but lots of other things, menopause add to it, stress, depression, things like that. Relationship changes, which is talked about. Orgasm difficulty, about a quarter of women experience orgasm difficulty. Arousal, so they can't get in the mood, and then the changes obviously with body image. However, for all this depressing news, there is help available, and it's knowing where and when and how to refer. So I'm on the personal opinion that every clinician should have a sexual counsellor that they work closely with and refer to regularly. These women or men who do sexual counselling are amazing. Their knowledge of sexual function and ways in which we can improve life of women and men as partners as well is fantastic. So I think the one stop, if nothing else, would be a sexual counsellor. So psychologist, who we're going to hear from later. So when we're dealing with all the really difficult emotions that come with cancer, and we're dealing with the partners as well as the woman, a psychologist is going to help a lot in dealing with those and improve that kind of sexual attitude side of things. Physiotherapy for dyspareunia, pelvic physiotherapy can improve things quite a lot. Vaginal estrogen. Studies have actually shown that the use of systemic HRT doesn't really improve sexual function. but vaginal estrogen significantly does. So the Ovestin or the pessaries, the cream or the pessaries can improve that and reduce dyspareunia. The use of lubricants and moisturisers, I think a good lubricant can save sex lives. And I tell all my patients, don't use KY jelly. It's what we use, it's what to examine you. It's what most people take off the shelves, but I think it's one of the worst lubricants, and we can get something that actually replicates a woman's own lubrication a lot better. We recommend silk, but there's a whole things around. You can use vaginal moisturisers as well to improve that vaginal dryness. So we've talked about dilators with Linda, and we're actually of the opinion in our practice that we don't recommend dilators, we recommend vibrators. Because dilators are very medical and they actually make the vagina very non-sexual, non-fun. You put it in, you put it out, and it's done. But if we recommend a vibrator, women have a lot of fun. They can involve their partners in this activity. They can often use their vaginal estrogen as a lubricant. So it's a way of also then putting in vaginal estrogen to the area, which is a little bit more fun than your finger. So we recommend and sell vibrators within our practice. And I recently sold a vibrator to a 75-year-old woman. She was excited and shocked, but I could see it was the first time that someone had actually offered it to her. We give her in a brown paper bag. She carried it out like it was nothing. And so for the first time in the 4 years that we've been seeing her, she's been using her vaginal estrogen regularly. So I think it's about making it fun, and as sex should be.
They come in different sizes?
Yeah, yep, they do, yep, and colours and shapes. And there are medical options as well. So with the removal of ovaries, there's a theory that testosterone. There's a drop in testosterone, so our ovaries produce testosterone, who knew? So you take the ovaries out, your testosterone level drops, and there's a theory that this is associated with reduced libido, but we do know that replacing testosterone will improve libido in 50% of women. So in WA we have a testosterone cream, but I don't know what is available so I have the 1% cream as well. And there's a recent study that came out that looked at the use of local anaesthetic aqueous solution applied to the outside of the vagina 3 minutes before intercourse can improve dyspareunia in patients with breast cancer. So we'll also look at that as a way to treat the pain, especially if it's pain on entry associated with dyspareunia. So yay, so we've got time now. I haven't got my 5 minutes. So I'm going to go on to the thing that all researchers love, and that's talking about their own research. So I'm doing my PhD in sexuality after risk-reducing salpingo-oophorectomy. And so risk-reducing salpingo-oophorectomy is in women that have increased risks of ovarian cancer, so our BRCA1, BRCA2, Lynch syndrome, those who have a family history of ovarian cancer, breast cancer. The recommendation is that we take out their ovaries and fallopian tubes at the age 35 to 40 or upon completion of childbearing. So these are women that don't have cancer. These are generally young women, and we are taking out their generally perfectly healthy ovaries and fallopian tubes and often putting them into premature menopause in order to prevent them from getting a terrible cancer that will effectively kill them. So the basis of the beginning of this was actually the Angelina Jolie, and she's a famous BRCA1 lady who had her mastectomies in 2013, and then earlier this year she had her ovaries and fallopian tubes removed. And it's because of her and the publicity that's gone with that, as well as the greater availability of genetic testing, that we're seeing an increase in the number of women that are coming to us requesting this particular procedure. So at my hospital, St John of God Subiaco, we've seen a massive increase in the number of women that are undergoing this procedure. And we estimate about 1,000 of these operations were performed in 2014 Australia-wide. So within our centre, we contacted all the women that have had this procedure in the last 5.5 years and asked them to participate in a study looking at their sexual outcomes and sexual experiences after this procedure. So we got a pretty good response rate of 57% out of the 205, and we asked them to do a very in-depth questionnaire which asked a lot of personal questions and was exceptionally long, so I'm very grateful for all those women that participated. And we also got them to get a blood test to look at their testosterone, sex hormone binding globulin and free androgen index, which is basically that testosterone that we were talking about before and the different levels of it. And so that's just a breakdown of the women that participated. About 30% had a confirmed genetic mutation, but a majority just had the family history that predisposed them to increased risk of ovarian cancer. Mean age was 50, but the youngest was 33, the oldest 67, and most of them had their operation about 2 years ago. So, what do we know about the prevalence of female sexual dysfunction? Now, I'm going to quote a completely different statistic to the one I used earlier, and that's because this particular study broke it down a little bit, so I could use their study for the rest of it. But a study of about 1,800 women in the US from 18 to 59 put their rate of sexual dysfunction around 43%. And what did we find? We found 74% of women in our cohort had diagnosed sexual dysfunction. Within sexual dysfunction, there's a whole range of things that can go wrong, and we've named one of them hypoactive sexual desire disorder, and that's basically low interest in sex, low libido, but to a level of personal distress associated with that. So we tested for the prevalence of that as well, and in that other study, 33% of women had that low desire, and in our study that was 73%. So over double the general population in our cohort had hyperactive sexual desire disorder. So this is a problem with doing things on Mac and then putting them. So what do they experience after risk-reducing salpingoophorectomy? So vaginal dryness is the first one. So over 50% of women experienced vaginal dryness that was troubling and distressing to them. 40% had painful intercourse, of which 20% of those had severe pain on intercourse. Sexual satisfaction is 40%, dissatisfaction, is 40%, low arousal 33%, and orgasm difficulty was 25%. And if we compare that to the general population, so about 10% of women have vaginal dryness in the general population, and we've got over 50%. Dyspareunia occurs in about 5% of the general population, we saw 44%. Low arousal occurs in about 5% of the population, we saw 30%, and orgasm difficulty is about 10% of the population, so we got at least double that. But what was most interesting to us was what was actually correlated with improved sexual function. And going back to our biopsychosocial model, relationship satisfaction was the best predictor of having a good sexual function afterwards. So the importance of sexual opportunity and a supportive relationship was the most important predictor for us in terms of who was going to have sexual dysfunction and who wasn't. So those in happy, supportive relationships and with high sex satisfaction reported the best sexual outcomes. But we can look at that on the flip side, because it's just a cross-sectional study, and say, well, do women who have really bad sexual dysfunction then affect their relationship or have a relationship that's affected by that sexual difficulty? So we can't say which way it goes, but we know that it's intrinsically linked to sexual function. Vaginal HRT, or topical vaginal estrogen, was associated, and high bodily pain. So women that had lots of pain generally didn't want to have much sex and had sexual dysfunction. So we looked at the that blood test that I was talking about to see if testosterone was in actual fact related to libido or sexual function, and we found that it wasn't, unfortunately. So doing a single blood test for a testosterone free androgen index did not correlate with sexual function. So although we know that testosterone cream can improve libido, it's actually not related to the levels themselves. So that kind of complicates that theory a little bit more, but it's for someone else to investigate further. So I'll just end my talk there and just reiterate that survivorship is more than about just surviving, and it's about looking at the woman and how she functions in her life after cancer. That's also important. Thank you.